it's because this is driven by patient demand. They know more about the golf clubs and guitars they buy than they do about the surgeon that's going to put them to sleep and operate on them.
The business of healthcare is hard, creating a badlands of terrain that is difficult to navigate. Some think the most brilliant minds in business are on Wall Street. They are wrong. The most brilliant minds are in healthcare. They have to be to thrive and survive. This podcast explores concepts in leadership, management, sales, and negotiation with those brilliant minds. The Healthcare Badlands podcast is generally planned, but unscripted, unedited, and uncut, so you get the honest and unfiltered experience. Your host is Dr. Tom McDougall, a 30-year veteran of healthcare with 23 years of hospital CEO experience. His guests are carefully selected experts from across the industry. They offer insights, expertise, and some great real-life, often hilarious stories. Now, let's jump into the episode.
All right, welcome to the Healthcare Badlands podcast. Today we have a special guest. It's Dr. John Porterfield. He is a professor of surgery at UAB, University of Alabama at Birmingham. He's also chief medical officer and founder for an organization called Informed Surgical Incorporated, and we're going to dig into that today some. I ask all my guests to provide just a summary of their background, a little bit about their bio. John began his bio by talking about his experience on his farm and growing up with his father and learning to work with his hands and solve problems at a very early age. He graduated from Auburn University, which isn't my favorite university, Roll Tide. But trained at UAB School of Medicine and then trained in surgery at Mayo Clinic. The UAB chair of surgery, Dr. Kirby Bland, challenged him to lead as he did. And John took that challenge very seriously. He got heavily involved in robotics very early in the development of robotics in the surgical field and has found a great success not only developing the program at UAB, but that same program has now carried forward across the U.S. and nationwide and its impact. In 2020, co-founded Informed Surgical Incorporated, which created a proprietary algorithm matching patients with surgeons based on objective quality outcomes while lowering the total cost of care. Through this time, he's stayed very focused on his family. And John, I'm very glad to have you with us. Appreciate you allowing me to call you John. I understand your patients refer to you as Dr. P.
That's right.
And I certainly like that. But I want to start off, John, talk to me a little bit about how you are keeping all the plates spinning, because between the practice of medicine, particularly as a surgeon and the demands that come along with that, and you're also leading the innovation of another company. So how do you do all of that?
Yeah, Tom, first of all, just honored to be on the podcast with you tonight. This will be fun. And, a lot of days I spin the plates better than others. So I think there is some variability in the plate spinning, but I think one of the keys to that is just the intentionality of scheduling. My wife Cassie is definitely the greatest thing that's ever happened to me, as far as not just personally, but also professionally, kind of helping me identify what looks good on paper or what looks good on an Outlook calendar, but what really doesn't look good in practicality. So that has helped really lead to building in margin in my life, whether it's, I think a lot of people think about like having weekends off and things like that. I do tend to get a lot of work done on weekends. I don't love the idea of like work-life balance because I don't think there's a great way to balance it. And I do think that it's all the plates are spinning at the same time. And so there's times that I'll get some margin during the week. And then there's times that there's margin during the day. Sometimes there's margin at night, and things like that. So I'm really, I think it comes down to intentionality, paying attention to calendars, and then really communicating really well with the ones you love so that they understand when you're going to be busy and when you're not, is really what it comes down to.
Excellent. Let's talk a little bit about informed, and what are you trying to accomplish with that? What are ultimately the goals? In the introduction, I explained, you're trying to match patients with surgeons, but
Right.
you mentioned outcomes, but what outcomes? Are we talking about satisfaction, quality, all the above? What are you trying to accomplish from the patient side and from the surgeon side?
Yeah, those are all great questions. And whenever we think about healthcare and informed, our vision is that all of healthcare should be outcomes based. And as you mentioned, there's lots of ways to measure outcome. And it could be something as objective as length of stay after surgery. It could be something as subjective as how the surgeon made the patient feel. I think there's value in that entire range from the most objective measures to the most subjective measures. And what we've done at Informed is we have built a complex algorithm that takes into account over a dozen unique data sources, some of which are publicly available data, some are proprietary purchase data, some is system and device data from some of the technology in the OR that we have exclusive access to some of that data. And then by putting it all together, you're able to build a profile of a surgeon. And one of the most important parts is that it's procedure specific, because there's a great example of a cardiac surgeon that was asked to do a splenectomy, and on a very famous person across the globe, and it wasn't the right match because they were a great heart surgeon, but they weren't a great spleen surgeon. So we really need to make sure that we're measuring that correctly. And then in order for surgeons to validate this, because all the surgeons will say that their patients are sicker or they're more complex, or a hospital will say that they see sicker patients than hospital B. We've had to risk adjust everything. And so that has been a key factor to understand what non-modifiable risk factors the patients have that they come in with. They come in with diabetes, they come with hypertension, they come with previous procedures and medical history. And then to really understand that, because the perfect match between a patient for a specific procedure with a surgeon takes into account more variables than we could accomplish without modern, artificial intelligence and machine learning algorithms that are now, I mean, they're now in everyday use, and we've been able to take advantage of that to get the right patient to the right surgeon for the best outcome at a lower cost.
Yeah, how are you perceiving the response of insurance companies? Because it's a lot of insurance companies, they're more show me and then we will talk about rates, we will talk about incentives, we'll talk about all those different things. Are you finding that you're having those delays where they want you to prove it first before they will recognize it and certainly compensate you for the high quality and satisfaction you're achieving?
Yeah, that's exactly right. And our very so the way we got off the ground was we went directly to several large self-insured employers, because they're the ones that are writing the check for their health care. They were identified by some friends of ours in the industry, in the healthcare broker industry, that these chief financial officers were feeling a very heavy weight of their healthcare expenditures rising every year. And their expenses were second only to payroll. So healthcare was their number two expense. So it was a pain point for them. So we went to them and we charged them a per employee per month rate to be able to lower their surgical spend. And we have done that with our first revenue back in 2024, spring of 2024. We're coming up on almost a year of that monthly recurring revenue. And now the large payers, like you mentioned, insurance companies, healthcare brokerage firms, now they are paying attention because we do have real world evidence that it's not a hypothesis anymore, that we are actually showing that we are saving around $10,000 per surgical procedure, not even the whole episode. It's more on the entire 120-day episode of care, but just on that single procedure, we're showing that that we're reducing that surgical spend by about $10,000 by reducing complications, getting the patient to the right surgeon, and by getting the procedure done with the correct approach at the correct facility. Because, for example, in the Bay Area, you can have a cholecystectomy for $9,500 or $53,000. Same outpatient cholecystectomy, 12, 15 miles apart, two different hospitals, with really, no, and what you pay more for, there's not a improvement in quality with that extra cost.
Yeah, that's definitely an industry-wide problem. So let's talk just a second though about how the insurance companies do you find that they are really starting to value the outcomes? Because it seems like so many times, in healthcare, whether it's from a hospital perspective or from an insurance company perspective, there's always this discussion of quality outcomes, and the insistence on, values being created. But then when the dust settles, they really aren't paying for it. So how is your company trying to bridge that to where there's an actual direct payment, direct incentive associated with those quality outcomes?
Yeah, I think I'll back up a little bit. Just part of it's just my own education and learning. As a surgeon, I thought insurance companies paid for everything. But I would separate it out into like the insurance on the fully insured side, and then an insurance company functioning as a third party administrator. So, for a large 10,000 person company, you know, they're self insured. And so that Blue Cross or United or Cigna, they're just the third party administrator. I learned that it's really more just accounting for the claims. And then, if someone just went to an insurance company and they got a fully insured product, then that fully insured company is actually writing the check for their care. So on the fully insured side, the insurers love our product. And that is where they are looking to add us in so that we would be more like an Intel Inside or
Right.
a BASF model where we don't make the things you love, but we make the things you love better, on the fully insured side. On the TPA side, they really have not given us much resistance or much access because they're not writing the check. It's the CFO of the large self-insured employer that's writing the check, and we haven't had any resistance or we haven't had any pushback from them writing smaller checks, and they're pleased with that.
Okay, excellent. Let's shift gears a little bit and talk about robotics,
Yeah.
because clearly that is, I can remember earlier in my career on the hospital side, I almost fought the robotics revolution, because of the additional costs that was being incurred, and we were having a lot of difficulty showing any cost savings because I'll be totally transparent. I was dealing with some surgeons that it would take them longer to do a gallbladder removal robotically than if they did it laparoscopically or even in an open procedure. So I was not an advocate, but over the last 5 to 8 years, I've become an advocate because I've seen the efficiency that's been achieved. And you've done a lot of training with the surgeons at UAB. So here's my question. How far are we from truly remote robotic surgery? The concept of a surgeon that is in Philadelphia doing surgery on a patient that's in Chicago. How far away are we from that actually occurring?
Not as far as you would think. Um, I was just on a call this morning with Maria Ilikova, surgeon. That's what we were talking about on our meeting this morning. Was how does Informed pair up as we've got this nationwide group of surgeons that are excellent. It's that surgeon of excellence network. We were talking about the synergies between how we could work with the structure that she's building for telepresence, which is what we talk about whenever if a surgeon is in, Tuscaloosa and they call Auburn for help, and that Auburn surgeon is just watching the procedure and giving advice. So that's kind of a telepresence. If it's going to be telesurgery, so now the operation's in Tuscaloosa and the surgeon is in Auburn, and the surgeon in Auburn is actually going to move the instruments. One of the key things there is data latency, which you would see on a speed test. It's basically best estimated by your ping, which we need to be continuously under 150 milliseconds, which if you checked your internet, you're probably at 12 right now. But it has to be very steady at that, so that if the delay exceeds that, then that is where there could be a sense that there's less responsiveness to the instruments. That's a long answer to say that we are already doing telepresence. I do that now, assisting surgeons remotely from a teaching and education proctoring standpoint. It's probably been 15 years ago that we did the first true telesurgery. They've done them across the Atlantic Ocean. And so it's technically possible. Until it's mainstream, I think that, it's probably a decade for all of the legal ramifications, licensing and things to catch up, because I'm licensed in 5 states, so I could do that in any of those states. But there's a lot of questions that would need to be answered that I think will slow things down more than the technology.
Okay. Interesting. All right. So I want to challenge you, and you don't know this question's coming, but I want to challenge you just a little bit on your outcomes. Okay. Because I'm just, research is research is research.
Yeah.
There is a tendency in research to be very careful in your selection process, so that, you are, I hate to use the phrase cherry picking, but you're carefully choosing patients to create the best outcomes, particularly early in a new company's life cycle, or if you're doing a research study or something along those lines. How do you address that so that the research data that you are publishing now or have available now is a fair representation of what would logically be accomplished once you have expanded out your population you're caring for?
Yeah, you're exactly right, because I do believe that like all data under duress yields significance in some way. I think most all investigators start projects with the end in mind, and they build the project to communicate that. And I think that's unethical in many ways. And so what we've done to combat that at Informed is that, and we're small, so that it's easy for us to capture all of the data on every consecutive patient. So there is no selection. There is no choosing. My team has no choice but to collect everything. And so we even have, a patient or somebody that may call us, reach out to us. And while we have built out a direct to consumer model, we've not gone live with that yet. But I was traveling, and a lady asked me, she overheard me in a conversation in the Sky Lounge, and she asked me a question and asked if I could help. And I said, yes, we can help. And so we even captured that patient to be able to see what advice that we give back to her. And so those types of events are good for us to learn from, but it also makes what we will eventually publish and make public, make it more reliable, because it's not a sample of it. Other quality initiatives like NSQIP, the National Surgery Quality Improvement Project through the American College of Surgeons, for some procedures, they collect all of the data For other procedures that are very common, they have a robust sampling method to try to make sure that they're collecting things and not missing things. But our plan is to continue collecting and publish on every single patient that rolls through our front door.
This episode is sponsored by CO Management Solutions, a revenue cycle company you may not have heard of, but you need to hear this. There's little healthcare organizations can do about inflation-related expenses, but you can make sure you are collecting 100% of the revenue you have earned. CO uses AI and the latest technology paired with an efficient team to aggressively collect your hard-earned revenue at an attractive commission. Start today with a free analysis of what you are leaving uncollected and recover that revenue with CO. For more information, visit coms.com. That is SCIOMS.com. A link is provided in today's episode notes. Going back just a little bit on patients. So you're working directly with employers, which is excellent. That's where a lot of this innovation is occurring. Are you seeing a lot of travel necessary? So, as a patient that may have to travel 100 miles or further to have their surgery versus if they had surgery just at a hospital that was closer to the region, are you seeing a lot of that right now?
No, because one of our key tenets of the company is that since it is a surgeon of excellence model, it's not a center of excellence model. It's because there's limited centers of excellence, right? Each state has a handful of them. But we know that there are spectacular surgeons that are at less well-known centers, and people just don't know their outcomes. They don't know their length of stay. They don't know, what they offer for minimally invasive procedures, and particularly in robotics, because just like with laparoscopy in the 80s, it was picked up first in the community and then later by academics. The same has happened with robotics. So some of the best robotic surgeons in the world are at hospitals that are largely, medium-sized community hospitals. And so we have a goal to be able to match patients with surgeons that are great, but that are close to them. And so for gallbladder, hysterectomy, inguinal hernia, we expect that the patients would travel less than 20 miles.
Excellent.
Now for pancreas cancer, I think that anyone on the Eastern Seaboard should see John Martini at Atrium in Charlotte, North Carolina. I mean, he's one of the most advanced pancreas surgeons in the U.S., and that's where we would do that. But and we would be able to support that travel for that patient to be able to do that, because that's not where for a highly complex procedure that demands expertise. He obviously is at a center of excellence. That type of patient, it is worth it to be able to. That's not the patient to save money on, right? That's the patient to make sure that you get it done just right, because complication rates after pancreas surgery in some literature is as high as 40%. So that's where you've got to get it to the right person. We might do the same thing speaking at the same institution, Vidra Augustine, right? We might send a patient for a complex ventral hernia because of their experience there. And so for rare things, travel is essential to get the highest quality. For common things, we have found that there's not a need to go much more than 15 or 20 miles for most patients.
And I would think that where you're not requiring the travel, you're going to have a lot more support from family members, friends. I'm sure that aids in the healing also. So that's a big plus. And that is a divergence from what we're hearing from, some of the early models where, you may be, traveling 200 miles and the patient's receiving, a $2,500 payment incentive to encourage them to to travel a far distance to go to one of these centers of excellence. So I really like that you're designing this to be an augmentation of the community as opposed to a replacement of the community service. So congratulations to you on that.
Thank you. The other part of that is, while we do gain a tremendous amount of information from the robotic systems, I do want to be clear that we are our true north is patient outcomes. So if it's done laparoscopically in an ambulatory surgery center that doesn't have a robot and their patients are doing great, that's fantastic. That's good for that patient. It's good for the company. It's good for America. That's great. You know, and there are very few companies that have tried to tackle the problem of figuring out who is good, which patient is right to be with that laparoscopist at the ambulatory surgery center, versus the patient that's not that much sicker, but they would benefit from 3D imaging. They would benefit from, the use of indocyanin green and the ability to use what's called Firefly to make the bile ducts glow and really be able to see well. And then the next level of patients are patients that do require a large tertiary referral center. Maybe they're on dialysis. Maybe they've had a lung transplant, things like that. So really being able to, as much as we have done to learn about the outcomes of individual surgeons by procedure, we've also built a patient complexity model that we're very proud of and we believe has worked well to actually be preemptively recommending to the surgeon which patients would be best in each of their facilities, because most surgeons nowadays operate at a minimum of 2 hospitals or 2 locations, and some of them operate at 5 different places. And those 5 places, you don't want to have surgery at one of them just because they're doing cases there tomorrow, if that's not the right place for you. So as a surgeon, I love the ability to be able to see kind of what that looks like on the intake. And then my team knows that this patient is best to be at this location.
Yeah, excellent. Okay, so you're kind of on the cutting edge, early stages of how data not only informs healthcare decisions, but is also contributing to improved outcomes. Where do you see this going? There's so much chatter just in the market. I mean, every company on earth now is trying to convince us that they're an artificial intelligence company. And I love
Yeah.
that you're not forcing that. You're talking about the reality of algorithms.
Yeah.
You're talking about using data effectively, but you're not touting artificial intelligence as a catchphrase. So I really like that. So where are you going long term as a company, and where do you see the industry going in terms of how data will be used for what's most important, and that is the betterment of the patients?
Yeah. So where we started, it's kind of like you start at home, right? You start with what you know. So we started with general surgery. We expanded to GYN oncology with some of our colleagues, Kenny Kim and Todd Tillmans, Michael Numnum, that were leaders in that area to be able to help us with GYN oncology. Next was then to take on the entire chest and abdomen with thoracic urology and all of those procedures. We're expanding into orthopedics next. And then once we kind of round out the house of surgery with spine and intracranial neurosurgery, then we will move into diagnostic imaging, which we've already started some because we were originally focused on just the surgical care, but now we've expanded out to the episode of care, because just like I talked about that range for a gallbladder that could be 50,000 to 10,000, an episode of care can be 50,000 to 200,000 for an episode, like around colorectal cancer is the example I'm mentioning there. So diagnostic imaging, and then we believe that all of the procedural areas open up after that. Gastroenterology, cardiology, nephrology, anything that has anything that in healthcare that we can measure objectively, how well do the patients do? Um, that's really our sweet spot. That's where we see it growing. And it's good that we've got validation of the market because we're not the only ones doing this. And so it's good that to see the sparks fly as we compete and on features, as we compete on quality of data, as we compete on quality of definitions and algorithms. And I think the country wins. And then, as that happens, we'll be able to expand into CMS, into the VA health system, and then internationally.
Okay. Well, that brings me to an interesting question. So let's fast forward to 5 years from now. Obviously, what you're doing and what some of your competitors are doing, it's a small percentage of total surgeries in the country. It's
Mhm.
it's not a substantial percentage by any means. But 5 years from now, what would be your best guess on what percent of surgeries would be in a model similar to yours versus, the traditional, really non-structured type approach?
Yeah, it's a great question. So right now, the country is pretty much split 50-50 in that about 50% of surgery is covered by CMS or a government payer, and about 50% is covered by commercial payers, whether it's through a TPA or self-insured, that type of thing, including Medicare Advantage. So, in 5 years, I believe that there will be, you know, I believe at least a quarter of that to maybe half of that. So you could see 25% of surgery being performed after the patient has been informed by a source like us to understand their options about and information about their surgeon. So I think that in 5 years, 50% of the available commercial market could be seeing this. And the reason it's not because us companies like us are that smart or that fast. It's because this is driven by patient demand. They know more about the golf clubs and guitars they buy than they do about the surgeon that's going to put them to sleep and operate on them. And the generation like our kids, right? Our kids know so much so quickly about things before they buy them, and they don't just take dad's word for it. You know, they want to see the data, they want to see the evidence, and that is not it's not only it's all sectors of society because everybody has a smartphone now and everybody wants to be an informed consumer, and that pressure is what's going to create this need for that rapid growth to happen.
Yeah. Okay, so let's pivot to one final topic. I want to talk about, so we've talked about your company, we've talked about the role of surgeons, we've talked about the expectations of patients. So they're playing a role in this also. But your background also is, well, for practical matters from a medicine perspective, it's exclusively UAB
Yeah.
and Mayo Clinic, which are two outstanding organizations that do an enormous amount of excellent training for physicians and have a lot of impact on the future of medicine. What's the role of those academic medical centers to advance and accelerate the work that Informed is doing? How do you navigate between your two worlds?
Yeah, it's interesting because there's a fair bit of difference between them. Um, our heaviest resistance that we have met from hospitals and health systems has been some of the large ivory towers, if you will. We have been turned down by just one very, very crisply because they said all of their surgeons should be informed for every procedure or else they wouldn't be working there. And
Interesting.
and so it was very poor alignment, and I was glad that they were so upfront to let us know that, and that allowed us to move forward. The At other centers, they have absolutely embraced it. They have helped us. Our IRB protocols that we're running are running through academic medical centers. They are hosting it on their RedCap servers, and so that's where we see working most with academics is on the research, providing grants for their fellows to continue, their fellows and residents and medical students to publish more academic works. That's how we see that. In the community setting, however, hospitals tend to be much more interested in working with us because they are driven more by, seeing more patients that are appropriate for their surgeons and hospitals coming through the door. And they like what we're showing as far as reduction in length of stay, even in their own hospital. If we can get the right patient to the right surgeon for the right procedure and lower their length of stay, that improves their throughput. So that's where that's been. I think UAB wisely asked me to kind of keep that separate. So took about a year to create the appropriate structure and legal documents so that I could still be a surgeon at UAB and I could be a chief medical officer. But we put some really smart rules in place about things that didn't cross between what I was doing on either side. That was important, and some wise counsel there. And it's been fun because I've had the opportunity to kind of create a new vision for my career moving forward.
Yeah, that's excellent. No, I agree with you. I think it makes a lot of sense to keep them separate, but it also, in my mind, it makes you such a stronger leader in both organizations where you have a foot now, because you're getting exposed to things that are non-traditional, that are innovative, and you can bring some of those things back to UAB. And at the same time, your involvement with Inform, the fact that you are still actively practicing surgery, will make you a better leader on the Inform side. So I applaud you for, not just picking up and jumping out of actually doing surgery for patients and becoming, one of the corporate people in an innovative company. So I think it's excellent that you're still doing both, and I'm sure it makes you stronger in both organizations.
Yeah, I do feel strongly that any chief medical officer, particularly of a surgically led company, there has to be there has to be that clinical currency, if you will. I think at some point, if I was ever to not operate, I think that the chief medical officer role would probably not be the right role for me in the company. I think that it's very important as we grow and scale. I would envision us having, active clinical practicing surgeons, as chiefs over large sections like orthopedics. Like I need a chief medical officer over orthopedics now, that type of thing. And I believe that's really where I see my skills leading in a little different way, as the company grows and scales.
Fantastic. Well, Dr. John Porterfield, I very much appreciate you dedicating time to do this. And I understand today is your birthday. So thank you. Thank you double for investing time on your birthday. And thank you so much for sharing with our listeners your thoughts. And thank you for your leadership in not only your organizations, but also in the industry.
Great. Thanks, Tom. It was fun. I enjoyed it and couldn't think of a better way to start my evening.
Thank you for listening to the Healthcare Badlands podcast. As always, please like and subscribe so you don't miss future episodes. If you have suggestions for topics or guests, please email those to podcast@badlands.pro. This podcast is for informational and entertainment purposes only and should not be considered legal advice. Some information shared may include fictitious names. The opinions expressed are solely those of the host and/or guests and are their own and not reflective of the opinions of others or our sponsors. Thanks again for listening, and we hope you'll join us on the next episode of the Healthcare Badlands podcast. Until then,